So I'm taking contraception for the AKT, basically the points that I think are relevant. I'll start with the combined oral contraceptive pill and the POP. So I'll start with the mechanism of action. So basically, the COCP inhibits ovulation by negative feedback. Kind of, I'm going to oversimplify it. I hope I don't offend anyone. I know everyone knows contraception, basically. But it tricks the body into thinking there's estrogen and progesterone, so it reduces the release of the gonadotropins, FSH and LH, so there's no ovulation. Also has some effects on the cervical mucus, the endometrium, and the tubal motility, but I think for the AKT, inhibits ovulation will be the answer. The POP also inhibits ovulation to an extent, thickens the mucus, thins the endometrial lining. So how do we start a person on the pill? If the lady takes the pill within the first 5 days of her cycle, she's immediately protected for virtually all of them. Or if she takes the pill after day 5, for the COCP, she needs to use an additional method, like a barrier method, for 7 days. For the POP, it's only 2 days. Then missed pills. For the COCP, if you miss one pill, no problem. But by the time it's getting to the 48-hour mark, so a person has missed 2 pills, then that's when it becomes a problem. If you miss one pill, just take the pill, even if it means taking 2 pills within a 24-hour period. But like I said, miss 2 pills is a problem. For the POP, it's kind of tighter. So the progesterone-only pill is a matter of hours. So by the time a person has missed the pill for 3 hours, they're basically no longer protected. But I think the rules for the POP were a little bit too strict, so they made the second generation. That's where you have the desogestrel, which is the Cesaret, which has a 12-hour grace period. So back to the COCP. I hope it's making sense. Anybody who has any question, just interrupt at any time. So a person misses her pill. It now becomes, where in the cycle did she miss the pill? If it's week 1 or during the pill-free interval, then she needs to go back on that barrier for 7 days. 7 days is usually the number to remember. But if it's the POP, then it's 2 days. For most of them, it's 7 days. If you can remember barrier for 7 days, you will mostly be covered, mostly. Right, so missed pill in week 1 or the pill-free interval, barrier for 7 days. If they've had unprotected sex, then they might need emergency contraception. If it's week 2 and week 3, they don't need emergency contraception. But yeah, just barrier for 7 days, basically. Then the last point, I haven't really seen it asked anywhere. I just mentioned it because I've seen it on the past medicine notebook. If a person is switching from the COCP to the POP, they're immediately protected. But if they're switching from the POP to the COCP, then they need barrier for 7 days. Right, so just some additional points. A question I've seen asked is about the risk of cancers with COCPs. So for protection, just remember O. So COCPs reduce the risk of bowel cancer, ovarian cancer, endometrial cancer. So bowel, ovarian, endometrial, you are protected basically with COCPs. The bowel one is the one that was a little bit surprising for me the first time I saw the question. But the COCPs increase the risk of breast and cervical cancers, can also increase the risk of VCs, cardiovascular disease, etc. When it comes to COCPs and acne, you can sometimes use them for management of acne, but there's one particular one, the Dianet. Dianet is used only for acne. It's not used for contraception because you will die Dianet from a clot, and you don't use it for more than 3 months for acne. Right. So patients who have had gastric bypass, gastric sleeve, any kind of weight management operation really cannot have oral contraceptives or even the oral emergency contraception, just because they have issues with their absorption. Right. Quickly mention postpartum contraception. So a woman with postpartum doesn't really need contraception up to the 21st day postpartum. After that, we can kind of talk about contraception. There are some methods of contraception that can be used immediately, but basically in that 21 days is the marker, right? So if a woman is breastfeeding and within 6 weeks postpartum, she cannot have the COCP. It's MEC4. If she's breastfeeding and it's after 2 weeks, then it becomes UK MEC2, right? What else? Yeah, so like I mentioned, even though we say 21 days, you can start the pulp, you can put the coils immediately postpartum. It's not a problem. But if you miss that 48-hour window postpartum, then it's best to just wait for 21 days before you put in the coil. Right. And if a person is going for surgery, stop the COCP 4 weeks before surgery. And then there's another question that comes out a lot. So if a woman is going to use the lactational amenorrhea method for contraception, then she must breastfeed, and that must be the only means of the baby's nutrition. No top-up feeds, nothing. So I think that's a question I've seen. Right. So the UK MEC criteria 3 and 4. So the UK MEC 3 is A, B, C, D, E, F, G, M, W. And UK MEC 4 is Mr. HIV Baba. So A in the UK MEC 3 is woman over 35 years smokes less than 15 cigarettes a day. B is for BMI greater than 35, so 35, easy to remember. Then BRCA1, BRCA2. C is controlled hypertension. D is drugs or epilepsy. F is family history of VT. G is gallbladder disease. M is migraine without aura. W is wheelchair, so just not as mobile as you should be. You can make 4 migraine with aura, recent TIA, uncontrolled hypertension, then prolonged immobility from surgeries like hip replacement, knee replacement, personal history of VT, so the person has had a VT, breast cancer, antiphospholipid syndrome, just thrombophilic states. Then, like I mentioned before, breastfeeding less than 6 weeks postpartum, age greater than 35, and smokes more than 15 cigarettes a day. I'm just trying to be really fast, so that's why I'm running through. But if anybody has any questions, please ask. So another form of contraception is the Depo-Provera. It just contains the medroxyprogesterone. It's an injection. It thickens the cervical mucus, thins the endometrium. It's given 3 monthly. But if a person doesn't come at the 12-week mark, they can still get it up to 14 weeks and they're still covered. It's a question. It's an injection, so you can't really, take it back once you've given. So it's not easily reversible. And the effects can last up to 1 year. And their periods might not return quickly. And it may cause loss of bone mineral density and weight gain. So if it's that bad, why give it? It's useful for people who want to avoid first-pass metabolism, those people with, gastric sleeve, gastric bypass, people on enzyme inducers, those kind of people. The Depo will be good for them. So implants, Implanon versus Nexplanon. They basically contain the same things, etonogestrel, but the Nexplanon contains something that makes it visible on X-rays, and I think that's why it was made. They last up to 3 years. Oh yeah, I mentioned that. And and it's giving SC, a little bit more superficial. Right, when you're starting the Implanon and Nexplanon again, 7 days, para for 7 days, if it's not administered within day 5 of the cycle. It can be used in people with VT history, with migraines. It can be given immediately after termination of pregnancy. So it's basically the best option for a young girl needing long-acting reversible contraception. It's reversible, unlike the Depo. Take it out, basically she'll get her fertility back. Side effects, menstrual irregularities, and it's kind of the same for a lot of the progesterogenic methods of contraception. Right. A question that comes up is a person gets the implant and she's still bleeding up to 3 months. Funny enough, you can give her the combined contraceptive pill with the implant. It's a question. You can also give things like mefenamic acid or whatever, but I think the answer there will be COCPs. Right. So the intrauterine system, levonorgestrel, we all know Mirena. There are a few others too. I've mentioned the Jdesu and the highly can't pronounce that, but I think those are the 3 that I've seen in the questions. I'm talking so fast. They don't do very much by way of inhibiting ovulation, but just remember the mucus and the endometrium, taking the mucus, thing the endometrium, right? So remember your ABC. J comes before K, comes before M. The Jdesu has a lower amount of levonorgestrel. The Kai whatever has an even smaller amount than the Mirena. So basically, it's kind of ascending order of the amount of levonorgestrel and the amount of time is licensed to be inside, the uterus. So 3 + 5 = 8. Jdesu can stay there for 3 years. The K1 can stay there for 5 years. Mirena can stay there for 8 years. But if you're giving Mirena for menorrhagia or for the progesterone part of HRT, it's only licensed for 5 years. Right, yeah. So this is just what I said before about waiting, that you can give it within 48 hours of delivery, or you have to wait until 4 weeks postpartum. Right. I haven't said very much about the IUD because I think that's pretty straightforward. You can give it immediately postpartum. Can also be used. It's actually the first line for emergency contraception, and it works instantly. You don't have to give it on day 5 or day whatever. It works instantly. No need for barrier or anything. So this is just a small table. Well, it's not a table, but a small slide about how quickly the different methods are effective. The IUD is instant, 2 days for the pop. The others are 7 days, unless they're given within the first 5 days of the cycle. Then this is a quick slide on emergency contraception. There are basically 3 types. You can have the levonorgestrel, the LR1, which is the ulipristal, or the IUD. The levonorgestrel can be given up to 72 hours after unprotected sexual intercourse, while the IUD and the LR1 can be given up to 5 days, so 120 hours. But a trick there is the IUD can be given up to, how do I put this? Outside, you can give it 5 days within the expected ovulation date, basically, not just 120 hours after unprotected sexual intercourse. Right. So the dose of levonorgestrel is 1.5 milligrams, but if a person is a little bit overweight or if they weigh more than 70 kilograms, then it's double the dose. LR1 is just a single dose, no matter how big a person is. And you can give the levonorgestrel and LR1 more than once during the cycle, because the IUD, that doesn't have that problem. But once you put an IUD in a woman for emergency contraception, you leave it there until she has her period. Well, if she wants to continue with the IUD as a method of contraception, then you can stay there up to 10 years, basically. So sometimes when people take emergency contraception, they vomit. If they vomit within 3 hours of taking it, they have to take it again. After giving the levonorgestrel emergency contraception, she can start hormonal contraception immediately with no problem. But if she's getting the LR1, she has to wait 5 days, barrier in the meantime. And also, if a person is breastfeeding or they have asthma, there are additional issues with the LR1. I think that is the end of my presentation.